This video presents a step-by-step overview of a sinus elevation with a ridge augmentation procedure. It begins with a case of a patient lacking posterior occlusal support. An assessment of the inter-arch space indicates adequate room to replace posterior teeth. The surgical technique involves making vertical releasing and crestal incisions, reflecting a full-thickness flap to expose the graft and sinus sites, and utilizing specialized drills to enlarge the opening for a sinus elevation. The Caldwell-Luc lateral sinus elevation drill set is used to carefully elevate the sinus membrane with irrigation, following a protocol that increases drill size incrementally. Hydrated Medtronic Infuse and Osteogen plugs, saturated with infused BMP2, are prepared and sectioned for placement beneath the elevated sinus membrane. Custom elevators assist with membrane elevation, and collagen-rich graft materials such as Osteogen, Puros, and Minerals serve as carriers for BMP2. The procedure details the placement of graft materials, stabilization using titanium mesh, fixation screws, and postoperative imaging to verify successful grafting and membrane integrity. The procedure concludes with periosteal separation of the flaps and primary closure of surgical incisions using both mattress and interrupted sutures. A 30-year-old female patient is currently in the stabilization phase of her orthodontic treatment. She presents with an absence of posterior occlusion, which has implications for both function and ongoing dental therapy. An occlusal view of the maxillary arch reveals that the patient is actively undergoing orthodontic treatment. Notably, the left side of the arch is missing all posterior teeth, including both bicuspids and molars. The right side of the arch is also missing the molars. The absence of these teeth significantly affects the patient's bite and occlusal stability, which have been included in the treatment plan for future. The left lateral perspective provides a clear visualization of the dental anatomy and tissue conditions in this region. Distal to the cuspid, a distinct area of keratinized gingiva is observed. This keratinized tissue is important for maintaining periodontal health, especially in the context of orthodontic treatment and planned future restorative procedures. Evaluating the extent and quality of keratinized gingiva helps inform both the surgical and prosthetic phases of treatment, ensuring optimal outcomes for tissue stability and patient comfort. The left lateral perspective provides a clear visualization of the dental anatomy and tissue conditions in this region. Distal to the cuspid, a distinct area of keratinized gingiva is observed. This keratinized tissue is important for maintaining periodontal health, especially in the context of orthodontic treatment and planned future restorative procedures. Evaluating the extent and quality of keratinized gingiva helps inform both the surgical and prosthetic phases of treatment, ensuring optimal outcomes for tissue stability and patient comfort. An evaluation of the patient's dental arches demonstrates that there is sufficient inter-arch space available to facilitate ongoing orthodontic and restorative procedures. To address the patient's lack of posterior occlusion and assist in opening the bite, a blue restorative material has been strategically placed. This restoration is intended to function in conjunction with a maxillary appliance, promoting improved occlusal relationships as the patient progresses through her treatment plan. The combination of adequate inter-arch space and the use of a maxillary appliance-supported restoration is crucial for achieving favorable functional and aesthetic outcomes. Prior to beginning the surgical procedure, the site is carefully prepared using a disinfectant to ensure aseptic conditions. Once the area is disinfected, a vertical releasing incision is made in the alveolar mucosa. This incision is positioned one tooth anterior to the proposed grafting site and is executed using a number 15 surgical blade. The vertical release facilitates access to the surgical area and provides sufficient mobility for subsequent flap reflection and graft placement. The occlusal perspective provides a comprehensive visualization of the surgical site, highlighting the extension of the crestal incision. This incision is carefully carried out, beginning at the designated anterior location and continuing posteriorly to the second molar site. As the incision progresses, it effectively splits the keratinized tissue, allowing for optimal access to the underlying structures and facilitating the necessary surgical manipulations. This approach ensures that the keratinized gingiva is managed appropriately, supporting both tissue healing and graft placement during the procedure. A full-thickness flap is reflected from the vertical release to the second molar site to expose the alveolar bone at the surgical sites. The sinus elevation procedure will be completed prior to the ridge augmentation anterior to the sinus. To facilitate the sinus elevation procedure, a full-thickness flap is carefully reflected anterior to the cuspid. This technique enables direct access to the planned graft sites, ensuring optimal exposure and maneuverability for surgical intervention. By reflecting the flap in this specific region, the surgeon can effectively prepare the area for subsequent graft placement, maintaining the integrity of the surrounding tissues and supporting the overall success of the sinus elevation process. The opening is performed by using the series of sinus elevation drills, gradually enlarging the opening with increasing reverse threaded Lindemann drills graduated in diameter, starting with 1.5 mm x 2.2 mm length graduating to the black drill 3.7 by 4.7 mm. The last gold drill has 4 flutes to widen and enlarge the osteotomy while displacing the sinus membrane with the bone particles that are removed. In this procedure, the DePlaque Caldwell-Luc lateral sinus elevation drill set was utilized to create the buccal window, a critical step for accessing the sinus cavity. This specialized set of drills is engineered specifically for sinus membrane elevation and is used in conjunction with continuous irrigation to ensure the procedure is both safe and effective. Irrigation helps protect the delicate sinus membrane and maintains optimal conditions until the graft material is positioned. The drilling protocol involves a series of drills that progressively increase in both length and diameter, with increments of 1 mm, ranging from 2.2 mm to 8 mm. Each drill in the set features a tapered design intended to advance bone particles forward as it rotates clockwise at speeds between 800 and 1,000 revolutions per minute. This design ensures efficient bone displacement while minimizing trauma to surrounding tissues. The final instrument in the sequence is a reamer-style drill, specifically designed to widen the osteotomy in the occlusal apical or mesiodistal direction, creating the necessary access for subsequent graft placement. This view of the drilling sequence indicates the relative size of the drills to the handpiece with a 20 to 1 gear. Once the buccal window was created and access to the sinus cavity was established, the next step involved careful elevation of the sinus membrane. Using specialized hand instruments, the membrane was gently separated from the bony wall of the sinus. This meticulous technique ensured that the membrane remained intact and undamaged while creating an adequate space beneath it. The resulting cavity below the elevated membrane is essential for accommodating the graft material during the subsequent augmentation phase of the procedure. The integrity of a membrane can be effectively evaluated using the Valsalvo maneuver. This method is a valuable clinical tool for determining whether a membrane remains unbroken. For the grafting procedure, Medtronic Infuse was prepared by hydrating 100 micrograms of the material with 0.5 milliliters of sterile water. Following Medtronic's recommended protocol, 10 by 20 millimeters osteogen plugs were partially saturated with infused solution. If you add too much water, the plugs get soft. This can be prevented by using the osteogen block. This careful preparation ensured that the graft materials were optimally conditioned for placement at the surgical site, supporting effective bone regeneration during the ridge augmentation process. After thorough saturation of the osteogen plugs with the 0.5 milliliters of the infused solution, the hydrated graft materials are set aside for a period of 15 minutes. This resting phase is essential, as it allows sufficient time for the BMP2 protein to bind effectively to the collagen matrix within each plug. Ensuring optimal protein collagen binding enhances the biological effectiveness of the graft material. Once this step is complete, the prepared osteogen plugs are ready for placement into the sinus cavity, specifically below the elevated and intact sinus membrane, as part of the augmentation procedure. After hydration with the BMP2 in 0.3 to 0.5 milliliters of sterile water, osteogen plugs are carefully sectioned to the appropriate size required for the size of the opening of the surgical site. The sectioned hydrated plugs were then placed in Puros, a bone grafting material, to further increase the overall graft volume. This combination supports the creation of an optimal scaffold for new bone formation during the augmentation process. Collagen-rich graft materials, such as osteogen plugs, osteogen blocks, puros, or minerals are essential and suitable as collagen-rich carriers for infused BMP2. These materials facilitate the effective delivery of the growth factor to the augmentation site for a period of 3 weeks, promoting robust bone regeneration and integration within the sinus cavity. Scanning electron micrographs of 3 materials reveal the detailed structures of osteogen puros and minerals. These materials are composed of bovine-derived collagen, which provides a natural scaffold and increases the material's overall density. The presence of these components is critical for the effective use of infused BMP2, as they support robust binding and integration of the growth factor within the graft matrix. The calcium apatite particles can be observed within the collagen fibers at medium magnification. The typical D-banding periodicity of the 65 nanometers cross-banding of the fibers can be observed in the 15,000x magnification. The combination of collagen and calcium apatite within osteogen plugs or block material creates an ideal environment for the delivery of infused BMP2 during bone grafting procedures. The dense structure ensures efficient protein collagen binding and optimal support for bone regeneration in clinical applications. These are scanning electron micrographs, SEMs of puros, a particulate collagen-rich graft material which works well as the carrier with BMP2. In the high magnification, the periodic cross-banding of the collagen fibers can be observed. An SEM of minerals cancellous collagen-rich grafting material is made by Medtronic and also serves as a good carrier of the BMP2. This graph illustrates the release of the BMP2 proteins over time after implantation in rats. It is suggested that the release period is similar in humans. Therefore, we recommend leaving the sutures for 2 to 3 weeks at the surgical site. Following graft placement, a clinical buccal view was obtained to assess the surgical site. This examination provided visual confirmation of the graft's position and the condition of the soft tissues surrounding the area. A post-operative CT scan was performed to evaluate the grafted region in greater detail. The cross-sectional image clearly demonstrates the osteogen collagen graft material fully occupying the sinus cavity. This radiographic assessment verifies the successful placement and adaptation of the graft material within the intended anatomical space. The ridge augmentation was performed at site number 13 to increase the width of the alveolar ridge and facilitate future dental restoration. The following techniques and materials were employed during the procedure. A DePlaque titanium mesh was utilized for the augmentation. This mesh was carefully positioned and secured onto the alveolar ridge using 2 5mm TriStar fixation screws. The purpose of these screws was to stabilize the membrane and provide a stable environment for bone regeneration. To further enhance the ridge width, the buccal wall was first perforated multiple times with a number 2 round burr to open the cancellous bone to provide a pathway for the cells to migrate into the graft material. An additional osteogen plug was placed at the site. This plug was supplemented with an additional 100 micrograms of BMP2, which promotes bone growth and supports the augmentation process. The post-operative cone beam X-ray clearly demonstrates the successful placement of both the membrane and the osteogen graft. These interventions were performed to increase the ridge width at tooth number 12. The radiographic evidence confirms that the membrane is properly positioned and the osteogen graft material has been placed to support wider ridge augmentation in the targeted area. The closure of the surgical incisions was accomplished using a combination of polytetrafluoroethylene, PTFE, and nylon mattress sutures. Both mattress and interrupted suturing techniques were employed to ensure secure approximation of the wound edges. The sutures, consisting of both PTFE and nylon materials, will remain in place for a period of 2 weeks to facilitate proper healing of the incisions.